Thank you very much to MPN Hub for the opportunity to speak in this session, which is really focusing on a very difficult to treat segment of our patients. Thank you to Jean-Jacques and Stefan. I'm now going to speak about how do we manage these patients in the real world setting. And I'm actually going to give you a clinical scenario. This is a real patient from our service in Southeast London. He's a male patient, 72. He's got very severe anemia and fatigue, bone pain, splenomegaly, and a pretty poor performance status. Otherwise, he has previously been fit and well, but I always like to ask patients about how their symptoms are impacting them. And this, I think, is notable. So it was important for him to volunteer, but he couldn't continue to do that. He has a high-risk DIP score, and he has these two mutations. And on the next slide, we can see his lab results. So probably what you'd all expect to see for this patient, given what I've already told you. There's some important information here that will perhaps guide our treatment choices. Platelets are 40, EPO's 750. I always like to test this before I give a JAK inhibitor. And the marrow is consistent with myelofibrosis. So we talked about impact of transfusions on likely survival trajectory for patients. We know it's a strong prognostic indicator. But actually really like this data, because it's a patient questionnaire, asks the patients, what's the impact on your life, various aspects of your life, and what's your perception of your experience in hospital? And you can see that the patients who are transfusion dependent here have generally, let's say, more negative scores. And there was also another very telling response that for 80% of patients who were anemic, it was extremely or quite a bit important to improve anemia as a treatment outcome and reduce transfusion frequency. So not necessarily totally ablate it, so not necessarily become transfusion independent, that's the goal, but even a 50% reduction in transfusion is impactful for these patients. So we've alluded to this already, but I would say that this patient fits into this category of cytopenic MF. We recognise, as you already heard, these patients have worse prognosis. There's also some biological differences. And they also sadly have fewer treatment options. But let's just take a look at what's the real world data. We've had a look at what is potentially out there in clinical trials, what are the data from clinical trials, but sadly many patients aren't eligible to enter a clinical trial for various reasons. So just concluding for this patient, his main issue was anemia and thrombocytopenia, although that wasn't causing him a clinical problem. He only has modest spleen enlargement. So these things would probably influence my choice of therapy for him. If I took a look at the British guidelines for managing anemia, they were published in 2024, authored by Donal McLaurin and the collaborative group in the UK. And they point out how important it is to look for other causes of anemia and then divide therapy options according to baseline EPO level. Using ESA if a patient has a subnormal level, and at that time we only had the opportunity of using danazol for patients that had a higher EPO level. Now, so danazol actually in the Momentum study was shown to be an effective agent, so don't forget it in your treatment options for patients. But now I modified this a little bit because we have the availability of momelotinib. And around 20% of our use of momelotinib in the UK is currently first-line therapy. The NCCN guidelines, more up-to-date, but slightly more complicated, also emphasising exclude other factors, largely also highlighting the importance of clinical trials. But then you can see a lot of other options outlined here, including pacritinib, and also the wider availability of luspatercept in the US, and highlighting that lenalidomide and prednisolone can be useful in some patients. For thrombocytopenic patients, the British guidelines for patients who... this is really about management of spleen and symptoms. Recognise that we can use ruxolitinib or fedratinib for patients with a kind of grey zone platelet count. And then for more thrombocytopenic patients, again, recognise use of danazol, low-dose ruxolitinib off-label, or momelotinib, or pacritinib in a clinical trial, or an IMiD. And unfortunately, many of those agents don't work very well for these patients. So we saw some data for momelotinib. Let's have a look at how does it look in the real world. This is some data from the GEM-FIM group, looking at patients with MF and transfusion-dependent anemia. And here are the results divided by JAK inhibitor pre-exposed patients. This is the majority of these 90 patients, or JAK-naive patients. And here you can see that the responses are pretty much what we'd seen in clinical trials. Among those patients with transfusion dependence, around 48% had achieved transfusion independence at 3 months, and 45% at 6. There's interesting and important data about thrombocytopenia in this bullet point here, with median platelet counts generally remaining stable. Symptom responses were also seen in the real-world setting, which is important. What about luspatercept? Well, I would say generally in Europe we don't have so much ability to give luspatercept to our patients. This is the poster from Gabby Hobbs, presented at ASH last year. Again, looking at patients who were requiring red cell transfusion. And you can see that luspatercept here for transfusion requiring or dependent patients did deliver responses at week 12 and week 16. And there were a large number of patients that had at least a 50% reduction in transfusion burden. So just reflecting that it's still impactful for patients to meet this target. In the real-world setting, several patients having very nice longer durability of transfusion independence. Many of these patients were already treated with a JAK inhibitor. And then also looking at responses to pacritinib. I think this is an interesting data set because this talks about bi-cytopenia response. So here you can see patients who had an improvement in hemoglobin, around a quarter of patients having a 1 gram response. Our kind of endpoint guidelines suggest a 1.5 gram increase is meaningful, so slightly less patients. Increases in platelet count seen incrementally over time. Need to think about that, whether some of that's due to washout of a JAK inhibitor. And symptom benefit also seen. So demonstrating that there are improvements in both anemia and thrombocytopenia in these patients in a real-world setting. So thinking about treating cytopenic myelofibrosis, I would say that there's sort of phenotype-driven selection of these patients, and that is actually largely supported, as I've tried to show you, by real-world evidence, which is very reassuring when it comes to treating patients who may have other comorbidities, as these patients often do. So we've seen data for momelotinib, pacritinib, luspatercept, and here is an algorithm suggesting, of course, that momelotinib can be used for anemia, thrombocytopenia. We can use both momelotinib and pacritinib. And if you're mainly treating anemia, then luspatercept can be useful. And I think the benefit of that agent is you can continue the underlying JAK inhibitor if you need to do so.